Good evening, doctors. My name is Rakesh Sonone, and on the behalf of FDC and MedTalk, I welcome you all to yet another episode of 52 Weeks Diabetes Essential by Dr. Sanjay Karla, Chairperson, Education Working Group, International Society of Endocrinology, past President, South Asian Federation of Endocrine Societies. And today's topic is diabetes and male sexuality. Before going forward, I would like to announce last week quiz winners. They are as follows: Shantanu Kumar Bhattacharya from Kolkata, Raju Handa from Delhi, Nakul Bansal from Panchkula, Surjit Kalsi from Noida, Anand Purandare from Mumbai, Ritesh Khanna from Navi Mumbai, Shashi Khare from Bhopal, Ashwini Kumar from Kanpur, Rakesh Bhargav from Delhi, Praveen Thakkar from Vadodara, Ashutosh Das from Tamluk, Surinder Gupta from Ludhiana, R.M. Tiwari from Mumbai, Dr. Vilas Sonone from Asti, Sanjeev Puri from Hoshiarpur, Satish Kumar Jain from Bangalore, Ravi Bhatt from Sirsi, Bharat Praveen Mittakola from Surat, and Sumita Sharma from New Delhi. With this, I would like to hand over today's session to Dr. Sanjay Karla, sir. Thank you.
Thank you, Rakesh, and good evening, everybody. Warm welcome to everyone who is logged in today. This is Diabetes Essentials, and we are concluding now our series of topics on glucocrinology. In glucocrinology, we focused on the various endocrine aspects of diabetes care. In glucocrinology, last week we talked about female sexual dysfunction, and today we'll complete this particular topic. We'll focus on male sexual dysfunction, what we can do in primary care practice to help our patients. Next week, we'll shift to visual disturbances in diabetes, a different topic totally. But let's begin with today's talk and let's share our screen. Now, like was taught last week by Dr. Bharti Kavra, sexuality is an important part of overall health. And when you speak of sexual dysfunction, the beauty of this diagnosis is that it is a diagnosis of the couple. The single person, the individual, may come and complain, but usually it is a couple based definition, especially when you talk about sexual inadequacy. Who diagnoses inadequacy? Inadequacy is diagnosed by the partner, or in some cases, the partners. Uh, Sexual inadequacy is becoming more and more common in society. Number one, people are living longer, so obviously sexual dysfunction will increase. Number two, chronic diseases such as diabetes, hypertension, dyslipidemia, heart disease, these are also increasing in frequency, in incidence and prevalence both, and all are associated with sexual dysfunction. Amongst all these chronic diseases, diabetes is emerging as a leading cause of sexual ill health, not only in women, like we discussed last time, but in men as well. And when you do a survey of men living with diabetes, you find that the prevalence of sexual dysfunction is nearly 50% in those who have had diabetes for about 10 years or so. Depending upon the study, depending upon the researcher, the prevalence of erectile dysfunction can vary from 30 to 90%. 90%. Now, sexual dysfunction itself is a very vast term. It's not limited just to erectile dysfunction the way we think. That's one statement we'd like to make. The second statement is that when you're handling men with diabetes, the pathogenesis of diabetes related erectile dysfunction is more complex. Erectile dysfunction is associated with endothelial dysfunction. The severity is more. The outcome may not be optimal. And also, the doses that we require to manage erectile dysfunction in people with diabetes are higher than what you would need in non diabetic men. So, all in all, the burden is higher in men with diabetes. But usually, what happens in the OPD is, or when your patient talks to you, you tend to jump to erectile dysfunction. So, do not do that. Let's go stepwise and let us look at the hierarchy, how we take a history. Let us look at how we view sexual function. Now, sexual function itself is a stepwise process. The first thing is libido or desire. So, libido means something that is there all the time. What is your desire for sex? Desire disorders, there may be men with hypoactive desire disorders, so they are less active. There also may be men who are asexual. Now, this is a debate that is going on. Let's try to put things in perspective. Now, there are some people who are hypersexual. There are other men who are hyposexual. Who decides what is normal, what is not normal? First of all, society decides. If hypersexuality reaches such a level that it becomes sort of damaging for the man's for the individual's personal and professional relationship, if it damages societal relationships, then it is a disorder. But if society accepts a particular level of hypersexuality, then it is not a disorder. Similarly, hyposexuality, hypoactive sex disorder, when is it a disorder? If nobody is troubled by it, that's fine. But if the partner in marriage or the partner in a relationship is upset, then it is hypoactive. So the couple will decide. A separate term is asexuality. Now, asexuality means not having too much of a sexual drive or sexual desire. Is this a disease or not? That is a question mark. Because when you accept various things as being normal, let us say we accept heterosexuality, homosexuality as being normal. We accept DEMI, sexuality as being normal. Demisexuality means, being demisexual means that first you develop an emotional bonding with a particular person, only then do you think of sex. So this is normal. We also have something called sapiosexuality, SAPIO. Being sapiosexual means that you are inclined or attracted to a person who is intelligent. This also may be normal. So then asexuality, if no one is affected by that, should be considered normal. So this is for desire disorders. Why are saying this so emphatically is when a person or when a couple comes to you in the clinic, just ask if there is any impact on that couple's relationship. If there is an impact on the couple's relationship or on the opposite partner's, the lady's satisfaction, then it is a desire disorder. Once desire is taken care of, then you move on to erection. So, erectile dysfunction is very common in men with diabetes. But do not jump to taking a history of erectile dysfunction until you have asked about desire. And do not jump to treating erectile dysfunction until you have handled the desire. Erectile dysfunction can occur because of various causes in people with diabetes: endothelial dysfunction, hormonal dysfunction, psychological issues, social issues as well, anatomic diseases like Peyronie's disease, like repeated melanoposthitis leading to phimosis. All these can cause erectile dysfunction. After erection, the next step in sexuality, in the sexual cycle, is orgasm. So, some people may have lack of orgasm, anorgasmia. Some may have delayed orgasm, but in the OPD, the commonest is premature ejaculation, very rapid ejaculation. So, this also has to be handled. But remember again, take a history in a stepwise manner. What is your desire like? आपकी इच्छा कैसी है? दिल करता है कि नहीं? सामने वाले को मिलने की भूख लगती है कि नहीं? Do you feel hungry to meet the person opposite you? After that, you ask about erection. ताकत है कि नहीं, शक्ति है कि नहीं, is there strength, is there power? And you can use other words in local language to ask about erectile function. Many times euphemisms are used. Euphemism would mean something like, let us say, just in a very casual statement, something that I use in my OPD: Pappu ka kya hal hai? Now, how is Pappu doing? Now, that can mean anything on earth, but when you are asking in this context, the person will understand. You can use analogies of different fruits, like maybe bananas or carrots, if you don't feel comfortable taking uh, the names of the normal words related with sexual anatomy or function. After that, we come to orgasm. Khushi, sukoon, tripti, nasha. These are words that are used by women, but men can also use khushi, sukoon, tripti, nasha. Or orgasm is just pani chhupna, releasing water. Does it happen too fast? Does it happen too late? And then the fourth is pain disorder. Are you comfortable throughout or do you have pain? Some people will say, I have postcoital headache. That can be a sign of hypoglycemia. Others will say, I have pain in the genital region. There might be an infection, a UTI, or maybe pyospermia. So, this is how we take a history order wise, and this is how we classify sexual disorders. Many patients will come with both things. So, very common will be the desire is fine, but there is no erection and there is premature ejaculation. So, first you fix the erection, followed by the premature ejaculation. Go order wise. Other people will come and say, I've just lost desire, I don't know why. So, then we fix up the desire, don't do anything about the erection, it might come back on its own. Always remember that in men with diabetes and also in men without diabetes, there will be a very important psychological and a social component. Psychological can be what kind of a day did you have at work today? Did your boss scold you all the time? Are you worried about losing your job? These might be causing sexual dysfunction. Do you get along well with your wife? Maybe you are friends with someone else before marriage. Has your wife's attitude changed towards you? Maybe your mother-in-law is nagging you all the time. You cannot get back at her because she is elder. So you get out you take out your frustration on your wife. Is that happening? So these are things to ask about and ask them slowly. But the challenge, all of you will agree with me, is that we know that these things exist, but we are not able to diagnose or treat them. So why is that so? This management should be very simple. One reason is that sometimes the external environment is not conducive. So many people in the OPD, no privacy. So what you do is try to achieve privacy. Fix up a system with your staff where you tell them that let's say you raise two fingers. So it means you want your staff to go out for 2 minutes. Raise one finger. You want your staff to go out for 1 minute. And that gives you 1 minute with the patient. And then you just begin asking questions, but do give privacy. This water approach, whenever you want a plant to grow, you have to water it. So, this is how to take a sexual history. Let's look at a few points. Welcome the gentleman warmly. Ask and assess. We'll talk about how to ask, how to assess. Then tell the truth, but tell it with empathy. Explain it with empathy. And reassure the gentleman and fix a time for return. Now, when you want to take a history, sometimes it's a bit difficult. So, we go from non threatening to threatening. If your patient says, Dak Sahab, I have weakness, kamzori, susti, thakawat, different Hindi words, Kannada words, Malayalam words. If the patient says, I have generalized weakness, or any kind of a pubic, suprapubic, infraumbilical symptom, the symptom can be pain, itching, infection, discomfort, anything below the umbilicus. Think of sexual inadequacy. Think that your patient is telling you that he or she has a problem. Insomnia, fear of going to sleep, hormonal disease. I think my hormones are not fine. All these are also surrogate symptoms of sexual inadequacy. How will we take a history? So you move from non threatening to threatening. So one example would be, sir, do you have any problem while passing urine? Too much or too little? Do you have to get up at night? This is quite non-threatening. Any infection in the private parts, or maybe any infection that you had earlier when diabetes was diagnosed. This is slightly less threatening. You are not being judgmental. You are not telling the patient, I suspect you of having a sexually transmitted disease. You are just going very casually. And the next is any kind of weakness, anything that I can help you with. Now, there are some languages let us say Punjabi, which I use. So, Punjabi lends itself to very easy history taking, and we'd like to ask everyone questions. Please answer in the chat box. Now, what do these sentences mean to you? Jawani kaisi hai, sir ji? Sir ji, or bhai sahab, or whatever you use. Jawani kaisi hai? And this is in Hindi. In Punjabi, Jawani Shivani kaisi hai? Now, this Jawani Shivani, this wordplay, it can mean anything that the patient wants it to mean, but you will get the message. And another way would be Jawaniyan theek hain ya Lahore reh gayi hain? How is youth, or has the youth been left behind in Lahore in Pakistan before partition? These are simple ways of probing in a nice and happy way. Keep on smiling and be non-judgmental. you will find that gradually your patients will begin speaking with you about sexual dysfunction. Even if they don't speak with you on the same day, they will come back the next week and they will say, Dak Sahab, last week you had asked me how was my youth. So that time I didn't understand or I was too shy. Now I'm telling you that I have a premature ejaculation or I have pain while passing urine or while having sex. Another word that we use in Hindi, which is very common, especially the women use it, that is baat karna. आपस में बात करना. आपस में बात करना literally means speaking with each other. But when your patient says this to you in the OPD, what she's saying is during intercourse. So if they say बात करते हुए दर्द होती है, what they are telling you is that while having intercourse, it causes pain. There's dyspareunia. So we patient will come back to you a week or 2 weeks later, or patient might bring his brother or brother-in-law to you or friend that is a doctor who knows about sexual dysfunction. That is why he took the history. So you will find that your OPD will grow in number and your patients will be more satisfied with you. In sexual dysfunction management, the major work is history taking. That will allow you to diagnose the phase that is affected. It will help you decide therapy and it will also help you decide appropriate investigations. Even if you are able to achieve nothing else, it is an integral part of patient education. It helps build a bond with the patient, and you will find that your patient will come back to you more happily for other care as well, for diabetes and acute care as well. But then the challenge is, and all of you will again say that I am so busy in my OPD already, how do I add this? So remember this poem from Rudyard Kipling, the first India-born person to win a Nobel Prize. And what he said was, I keep 6 honest serving men. They taught me all I knew. Their names are what and why and when, and how and where and who. So do ask this much. What are you feeling? Why do you think this issue is there? Is there a psychosocial angle to it? When do you have erectile dysfunction or premature ejaculation? Is it with every partner at every time? Or is it partner specific? Maybe situation specific. How do you feel? And like we said, is it partner specific? That's who. At the same time, Rudyard Kipling says that they talk about a young girl and she keeps 10 million serving men. So she keeps on asking 10 million questions every time. That's the elephant's child. So don't ask too many questions also, otherwise your patient may get afraid. Once you've taken a history, you will have a fair idea of whether it is a libido disorder, a desire disorder, an erection disorder, or maybe an orgasmic disorder. Routine renal, hepatic, and heart tests should be done because chronic kidney disease, chronic liver failure, and heart failure all will be associated with sexual dysfunction. Hormonal causes are not many, and usually they will be linked to lack of desire. So, lack of desire, testosterone may be low, TSH may be high, prolactin may be high. So, get 3 tests done: testosterone, prolactin, and TSH. But if your patient is very confident that, sir, I am always hungry for intercourse, libido is fine, then usually testosterone will be fine and prolactin will be fine. You can be sure of that. If it is an erectile dysfunction, chances of hormonal deficiency are less, chances of metabolic deficiency are higher. So, high blood pressure, high cholesterol, low blood pressure variability. All these will be more common causes. And if there is a pain disorder, then you may have to do imaging. There might be an issue with the anatomy. Now, penile Doppler is something that we should be doing, but it's a bit cumbersome for patients and also for the radiologist. So, in penile Doppler, what you do is you send your patient to the ultrasonologist. He or she does a Doppler of the penile arteries, that is the pudendal artery, then gives an injection of papaverine, or sometimes they give a tablet of sildenafil sublingually, ask the patient to self-stimulate and come back after an hour, and then they do the test again. But usually in the Indian context, it is very difficult to find so much privacy that the patient enjoys the the test, the investigation. If, however, a papaverine test is negative, that means there is inadequate artery vasodilatation even after giving papaverine, then a penile angiography is indicated. But let's come back to this slide. Routine tests, including glucose control, prolactin, TSH, and testosterone. These are the routine tests that we would do medically. Now, how do we treat? First of all, basic care, healthy diet, healthy physical activity, these are important. Tell your patient that even the sexual act itself requires muscles. So, if your muscles are deconditioned, if you've not exercised at all, obviously they will get weak. So, begin walking, begin exercising, exercise the proximal limb, the proximal muscles of your lower limb. Overall, when we lose weight, then also sexual function improves. This is because testosterone, our endogenous testosterone, when it enters the adipose tissue, it is broken down by aromatase enzyme into estrogen. So the more obese we are, the more our testosterone will break down, and the more we will have, the less testosterone we will have, and we will have more estrogen. So correcting obesity itself will improve sexual function. Yoga can be advised and various maneuvers with focus on subpubic, suprapubic exercise, muscle exercise. These can be advised. Nutraceuticals are something that I use in practice, and I'll just share what I use for each specific phase. But the most important would be psychological therapy. So, first of all, you get the gentleman to relax. Tell them to relax. You might use the help of a psychologist or psychiatrist and ask them to go slow. So tell them that the sexual act has got many phases. You don't have to jump to erection itself. So what one of the ways in which I speak to the couple is, or to the gentleman if he has come alone is, why don't you touch your partner's body, each and every part of the body, in each and every way possible. Touch your partner's body in each and every way possible and spend a week doing that. Don't even think about penetration. Begin by touching the non-erogenous zones. Non-erogenous zones. Then you move on to non-genital erogenous zones, which can be the breast area, the nape of the neck, the axilla, and then you move to this genital area. And so far, we are focused on non-penetrative sex. And then after that, you go for penetration. So, and take a week or 2 weeks, you have an entire lifetime to correct yourself. Don't worry. Sometimes the entire lifetime is not there. Let us say the gentleman is working abroad or in the armed forces and he has to go back after a week. Then everything becomes a bit faster. You can also talk to the person and tell him that tell him to find out what he's stimulated by. So another homework would be, why don't you watch a naughty movie on YouTube every day, but each day it has to be different style. So see what you like and what you don't like. Some people may be stimulated by one particular thing, others by another. All are normal, so don't worry. Eclectic therapy means a little bit of all this. So that is what we do. A little bit of relaxation, little bit of Masters and Johnsons. That means going stepwise from touch, non-penetrative, non-genital to non-penetrative genital to penetrative. We also teach all the various other things, including vivid imagery. So, imagine yourself on a beach and see what is it that makes you most excited if you're alone. You have the partner of your choice, you have the technique of your choice. So the gentleman comes, yes, I thought, and this is what I really like. So you say, why don't you share it with your partner? And she will help you do that. So all this is psychological therapy. Along with it, we give pharmacological therapy, which is of two types. One is nutraceuticals, the other is our proper modern drugs. Now, in nutraceuticals, what do we use? We use carnitine if you want increase in sperm count. Salbutamine, this is an activated vitamin B1. Salbutamine, one tablet once a day or two tablets once a day. This is used for neuroasthenia or to increase libido. It is an activated vitamin B1, no need for any investigations. Another drug that I use, a nutraceutical, to increase libido is yohimbine, 4 milligram once a day, very, very rarely 4 milligram twice a day. But if your patient is already anxious, then yohimbine should not be given in high doses, like 4 milligram BD or TDS should not be given, stick to 4 OD. If your patient has resting tachycardia, again, yohimbine is not a good drug to give. So we have spoken about salbutamine, yohimbine. A third drug that I use, which is a hormone actually, is DHEA, dehydroepiandrosterone. You can get a test done, dehydroepiandrosterone sulfate. But even if you can't get the test done, patient can't afford, and you feel that you want to give a very light kind of a testosterone, then DHEA is an adrenal androgen which goes into the body and is broken down into a balance of estrogen and androgen, depending upon the sex of the patient. So in men, it will break down to androgen. So you can use DHEA 25 milligram OD or PD. This will improve libido. So salbutamine, uh, yohimbine, and DHEA, these are drugs that we use for increasing libido. Now, hormone therapy will be given only if there is hormone deficiency or abnormality. So if TSH is high, give thyroxine. If testosterone is low, you give testosterone. You can give oral, injectable, or gel. If prolactin is high, find the reason, and if it is actually idiopathic or there is a microprolactinoma, then we have to give cabergoline. Along with this, if your patient has got erectile dysfunction, then the drug of choice is phosphodiesterase inhibitors. The one which I use most frequently is tadalafil, 5 milligram to begin with, go up till 10. Very rarely, very, very rarely 20 milligram. Mostly 5 or 10 does the trick. In diabetes, 10 milligram. In non-diabetic men, 5 milligram. There are different ways of using it. So I give it at night, every day, every night for a few days. And once the patient feels comfortable, we tell them to take on an SOS basis, once or twice or thrice a week, whatever they feel like. If patient says, "Sir, I need this drug for the next 10 days for whatever social reasons," then you can say you take it continuously, but the maximum dose is 20 milligram per day. Tadalafil will act within 1 to 2 hours, and the action lasts for 8 hours or so, 4 to 8 hours. If you want something immediate, then sildenafil is a good drug. Sildenafil 50 milligram oral, sublingual preparation is also available. This will act fast, and the action will last only for 4 hours. So, in some situations, patient may prefer sildenafil. In fact, there is a concept known as top-up therapy as well, which means you give tadalafil regularly and sildenafil SOSs. So it is the same drug class, and you are giving a baseline with tadalafil and you are adding with sildenafil. For patients who have got premature ejaculation, there we teach them exercises. So what I would tell my patient is, see, uh, if you're hungry for food, let's say we have starved you of food for the past 7 days, any kind of food that you see, you will begin to salivate. Similarly, if you are starved of intercourse, the moment you think of it, uh, water will come out. So this is normal. Basically, what it means is get rid of your fear and come back and sort of increase your frequency of self stimulation or of being with your partner or both, and increasing the frequency of intercourse, whether self stimulation or with partner, that actually improves erectile premature ejaculation. But the drugs to use are depoxetine. You can give depoxetine 30 milligram SOS. I prefer to give continuous for a month or so. In that time, the patient becomes fine, and then use on an SOS basis. You can also use sertraline 25 or 50 milligram at night. One other psychotropic drug that we use for erectile dysfunction is trazodone. Trazodone is a mild antidepressant, very rarely used in psychiatry, but the side effect is erectile function improves. It is the only antidepressant which is associated with improved erection. So you can give trazodone 25 milligram at night. This will be used in persons who have got a strong anxiety overlay. So let's repeat what we have discussed so far. For desire, you can use salbutamine, yohimbine, or DHEA, dehydroepiandrosterone. If there is a hormonal deficiency, then you must add testosterone or thyroxine or prolactin lowering drugs. These will improve desire. Apologies. For erectile function, tadalafil or sildenafil or both of them together also. For premature ejaculation, depoxetine continuous or SOS, along with very rarely sertraline 25 or 50 milligram. And if your patient has got anxiety, trazodone 25 milligram, which is a very mild antidepressant that can be given for a short period of time. But these are the active pharmacologic interventions that we do. Another intervention that we have to do is to do a drug review and look at the drugs that the patient is taking. Antidepressants, antipsychotics, lithium, all can cause erectile dysfunction. Blood pressure medications, especially beta blockers and diuretics, all can cause erectile dysfunction. So can antihistaminics, anti-cancer, and anti-HIV therapy. Finasteride, which is used for benign prostatic hyperplasia, reduces sexual function while increasing testosterone. Even the drugs like so innocuous drugs like proton pump inhibitors, they are also associated with sexual dysfunction. High dose statins, they too can cause sexual dysfunction. So be aware of these and try to reduce all the non-required drugs whenever a patient comes with sexual dysfunction. I think in my practice, the biggest culprits would be antidepressants and beta blockers, followed by diuretics. Now, with this, let's come to our quiz questions for today. So the first question is, which is the most common sexual dysfunction in men living with diabetes? Is it erectile dysfunction, premature ejaculation, low libido, or delayed ejaculation? Let's repeat the question again. Which is the most common sexual dysfunction in men with diabetes? ED, premature ejaculation, loss of libido, or delayed ejaculation? The second question is, which of the following lifestyle factors can help manage sexual dysfunction? Which of these help in sexuality in men with diabetes? Is it smoking, sedentary lifestyle, healthy diet and regular exercise, or excessive alcohol consumption? Which of these help manage sexual dysfunction? Smoking, sedentary lifestyle, healthy diet and exercise, or excessive alcohol? With this, let's look at our questions for today. Today is actually a very interesting topic. Oh, and we thank Team FDC for all the 0 day feedback that they have collected. And we thank everyone who is logged in today. For Sanjeev Grover Sahab from Karnal, he asks the question, how's the Josh? So the answer is high, sir. Josh is high. That's another way of asking your patient, how's the Josh in the OPD? Again, the patient can choose to uh, choose to understand it in whatever way he or she, whatever way he feels. We are talking about men today, but when you say how's the Josh and you do how's the Josh, actually if there's an issue, patient will come up with you. Warm greetings to Dr. Aditya from Chennai. It's nice having you with us, Aditya. And also good evening to Dr. Siddharth from Mathura. Good evening. Happy to have you with us. And Dr. Gauri Shankar sir, welcome. Dr. Gauri Shankar sir is from Karnataka. Yes, Nitin, sildenafil and tadalafil both are safe. Tadalafil would be a first choice, a better choice, but both are absolutely safe. Yeah, memory loss is there in people with diabetes. I think the workload is too much. I read somewhere that the maximum number of meaningful relationships that any human being can have is 150 at a time. But now if we see, we have more than 150 WhatsApp messages every day. So it is so confusing handling so many things together. I think to the young people, we say good glucose control, regular exercise, uh, be socially active. Social activity, social contact is one of the best ways of preventing dementia. Learn something new like crosswords, Sudoku, a new language. Entire last year, I learned Latin. This year, now I'm thinking of what to do. I learned Latin for 365 days. So, prevention of memory loss would be better. And that is be socially active, but limit your social interaction to a few meaningful people. Don't, go into 1,000 Facebook friends and 1,000 WhatsApp friends. And also learn something new, a new game, a new sport, a new hobby, a new language. If both sildenafil and tadalafil do not work, then a penile Doppler is indicated. There might be a venous leak. If there is endothelial dysfunction that you are suspecting or which you see on the penile Doppler, then to highest dose of tadalafil, 20 milligram at night, we can add arginine, 3 grams sachet twice a day. arginine 3 grams sachet twice a day, and you can also add trazodone 25 milligram at night, increase after 10 days to 50 milligram at night. This should do the trick. So tadalafil 20, trazodone 25 or 50, and arginine twice a day. Natural foods to improve sexual function would be healthy diet, colored fruits, colored vegetables, colored salads. So these have got more antioxidants. So whatever is available in season, we can tell our patient to take that. So for premature ejaculation, the commonest that I use is Depoxtin 30 milligram at night for a month or so, and then on SOS basis. If it doesn't work, I add sertraline 25 or 50 milligram. So that is what I do in practice routinely. Okay, now 74-year-old gentleman, this question raised by Dr. Deepak Rai Singhani. See, at 75, certainly patient will have poor response because of erectile dysfunction. Do a serum testosterone and PSA, prostate specific antigen. If testosterone is on lower side, add testosterone, that will help. At 74, we assume that he will have testosterone deficiency, but please do not treat without doing the test. And the minimum test so that we remain safe, that would be PSA and also hematocrit. Melanoposthitis is becoming more and more common in OPD. So stop SGLT2 inhibitor. Teach genital hygiene. Wash with water. Do not use Dettol or Savlon soap. Use only water. And use local cream, luliconazole, along with maybe fluconazole 150 milligram OD for 7 days, or terbinafine 250 milligram BD for 7 to 10 days. So genital hygiene, stop SGLT2 inhibitor, use local cream, luliconazole is used frequently, and also one oral antifungal. Both will have to be given. Good evening to Mr. Sachin Bhatia as well, who is industry leader from Haryana. It's good to be with you, Sachin. Dr. Gauri Shankar shares a challenging case, 29-year-old gentleman with high glucose levels. If we are giving glimepiride 1 milligram having hypo, we have to teach him 3 plus 3 meal pattern, small frequent meals throughout the day. He will not listen to you if you say these will help sugar. So what you tell him is, if you take 3 plus 3 meal pattern, it will improve your productivity in the bank. And you can scare him also a little bit. You know, sometimes hypo and hyper occur. So this is how I'll speak with this employee. What can happen is, maybe, you know, young man, you are signing a check in your bank. Uh, with hyperglycemia, with hypoglycemia, you actually might up adding a zero or so. So you have to pay out, let us say, 3 lakh rupees, and you will end up paying out 30 lakh. So to prevent that, because otherwise we will get in real trouble, you and your bank manager and I, all of us will get in trouble. So make sure you don't sign any big check until you have had something to eat. That something to eat should not have oil or ghee. It should not be simple sugar. It can be fruit. It can be a chapati or idli. It can be any non-processed food. So if you tell your patient about this, so see, one thing, need for achievement. 3 plus 3 meal pattern will help you be more productive. Second is fear of failure. If you do not take a 3 plus 3 meal pattern, you might end up failing you because you might end up signing the wrong check. Put both together and you will find that your patient will listen. Once that happens, the melanoboscitis will become okay. Yes, and uh, another challenging point from Mr. Grover is that new generation approaches a girl and then they go into depression because maybe they don't succeed in that, and this impacts their desire later on. That is true. The answer for this would be just improve self confidence, believe in yourself, and you will be fine. Now, when you go to, this is without being sexist or gender biased, but this is what my teacher taught me when I was in college. He said, when you go to Chowda Bazaar in Ludhiana, do you buy the best first sweater that you see, or do you go and see different shops, different sweaters, and then you buy one that you want? Similarly, if somebody has said no to you, doesn't matter. You, there'll be a better person waiting for you, so you go out and find her. Dr. Deepak asked about Duvoxetine tadalafil. My experience is very good actually. So this is what I use most frequently in the OPD. Duvoxetine 30 and tadalafil 10. Okay. If we give, Dr. Gauri Shankar says all three, 2 or 3 oral drugs is fine for glucose control. We should not be using 4 drugs, but I do use them sometimes, though ideally we shouldn't. But all three we can give, and now fixed dose combinations are available. So you can tell your patient we are reducing the number of tablets. And yes, Grover Saab, the Josh is high. Yes. Uh, Thank you for everyone who has answered the quiz questions here. Dr. Lambe says, can we give paroxetine prolonged release? Yes, I do use that. Paroxetine in my OPD is the commonest used in hot flash for postmenopausal women. And sometimes I do use it for men with premature ejaculation. If they are not able to tolerate sertraline or they are not responding to depoxetine. Good evening to Alim Zakat ji as well. And Aditya, yeah, penile implants, these are used quite frequently by our urology colleagues. Why I did not discuss today, Aditya, is because here Diabetes Essential is focused mainly on primary care. In my practice, I think earlier I used to refer patients for penile implant more freely. Now we don't. I think the drugs are better now. We have better drugs, and with tadalafil and associated drugs, we are usually able to manage. The trick is actually counseling. The trick is making the gentleman feel confident, feel comfortable. That is two things. Also, couple therapy is what is missing in India. If the couple comes together, then you know that you have hit the target. Then the patient will become file. If the female partner is cooperating, then the patient will be okay. Dr. Gayatri asked about empagliflozin. Empa is a good drug. We must use it. Gliflozin should be used in everyone with type 2 diabetes unless contraindicated, unless there is recurrent melanogastritis or pruritus vulvae. And if you are able to use that, then glucose control is better and erectile function will also improve. Some postmenopausal women may develop a chemical vaginitis because of empagliflozin. Because of the high glucose coming out, it will not be fungal, it can be chemical. In such women, there may be dyspareunia, so we should be aware of that. The treatment will be estrogen cream. And Dr. Akshay Devan asked about hypothyroid and anxiety. That is related. It's called thyroid distress. And if you overtreat, then palpitations can occur with thyroxine. If the TSH is normal, even then palpitations can occur. So the treatment is you can tell the patient to take the thyroxine late night before going to bed, last thing before switching off the light, at least an hour or two after your last meal or glass of milk. And or you might wish to add a low dose of beta blocker, maybe bisoprolol 2.5 milligram. 50-year-old gentleman from Karnataka, 400 glucose random, sudden slurring of speech and Lachner infarct. Yeah, not good idea to keep in general practice. We should send to the ICU immediately because they will give IV fluids. And if the patient has come within the first 1 or 2 hours, they can actually open up the arteries. And the results will be gratifying. So it is a good idea. The first aid will be aspirin, 150 milligram, high dose statin, 20 milligram rosuvastatin or 40 milligram atorva, single tablet, 150 milligram aspirin, statin. If the BP is high, you give a very light medication. Don't bring the BP down low, very fast and refer for admission. Thanks, Aditya, for your kind words. Okay, anxiety and palpitations aren't due to hypothyroid since TSH is stable. Try to take the thyroid tablet at night, Akshay, and then see what happens. And it might be something else. So then a beta blocker, bisoprolol 2.5 milligram OD, and another drug, ivabradine, 5 milligram tablet is there. Try half tablet once a day. Ivabradine 2.5 or bisoprolol 2.5. Ivabradine, there will be hardly any contraindications. So just talk to your endocrinologist and then see what happens. In addition to nitrates, what are the options for spasm? So love immunity with spasm like chilblains. Niacin is something we used earlier. Sometimes use multivitamin 3 times a day so that we can give high dose of niacin. But if you could just specify what spasm means. Thank you, Gayatri ji, for your kind words as well. And now we have many questions from the Zero Talk Day. Dr. Umesh Chandra Gedia from Surendranagar, Gujarat. Thank you, sir, for being with us, and we will make sure that the link reaches you every week. From Gola, Uttar Pradesh, we have Dr. Ravindranath. Glucose level has been 250 for the last 2 months. Okay, gliptin. Sir, here let us add sulfonylurea plus metformin. So maybe metformin 500 milligram plus glimepiride 1 milligram twice a day, or metformin 500 milligram plus glyclazide 60 milligram twice a day. Begin with this, continue the gliptin, glucose will come down. We will have to add sulfonylurea in this patient. Secondly, ask the patient about diet. Commonest cause patient will be eating ghee or oil. So he will say, yes, I take extra ghee or extra butter. So we stop that. Uh, Another common thing would be sweets. Halwai wali mithai. He's taking sweets, so ask him to stop that. So first would be diet. Second would be infection. Maybe patient has got tuberculosis, melanocystitis or pruritus vulvae, diabetic foot, otitis media, uh, cholecystitis, very mild cholecystitis. So just ask about these histories, UTI. And from Telangana, from Suraram, we have Dr. Satyanarayana asking about hypertension and diabetes. So it is almost, usually it is essential hypertension. It is part of aging, but because the diabetic person ages faster, in them hypertension will occur faster. And usually you will have to give two drugs together, usually. Type 2 diabetes does affect heart rate. Yes, this question is also from Suraram in Telangana, Dr. Krishnamurthy. It does affect heart rate, and many times yoga will help. Other times you have to give beta blocker. Thank you, Dr. R.K. Ghai from West Delhi, sir, for your kind words. And also Harish Bhatia ji, Sumedha Chipperji. Thank you so much for being with us. Dr. Sanjay Gogia is also with us. So thank you for all your 0 day feedbacks. One last question we have. Oh, okay. Spasm. If it is coronary artery spasm, then, and this is unstable angina, then love humanity. If the patient gets increase in frequency or increase in severity of angina during winter, this will classify as unstable angina. You can give nitrates, you can give other drugs also, but then ideally patient should get an angiography and angioplasty done, because this can be life threatening. So we should counsel the patient to go to a cardiologist, and there will be no ifs and buts about this. If it is unstable angina, patient should go. Frisium, petrol, beta, and so Akshay, really you should speak with your doctor. They're already giving you the right medicines, and it is not that you need to come off your anxiety medicines. It is that you need to take care of the anxiety. We can do that with yoga. We can do that with medicines. We can do that with other things. So maybe we can go back and consult the endocrinologist and perhaps psychiatrist as well. They will help you with the right decision making. Try to take the thyroxine at night and see what happens. That might help some of your symptoms. With this, I'd like to thank everyone who is logged in today. It's great being with you. Even though it is so cold here in North India, we see that everyone has logged in on a Sunday night. One last comment from Dr. M.A. Lambe. Thank you, sir. I'm reminded of this movie song. The movie is Saat Khoon Maaf. And the singer says, Sorry tujhe, Sunday ke din, zahmat hui. Apologies, we troubled you on a Sunday. Uh, and this is from Aditya. Sorry, we troubled you on a Sunday. Sorry, तुम्हें Sunday के दिन जहमत हुई. मिलना तेरा फजले खुदा रहमत हुई. Meeting you, this was ordained by God, by Khuda. And it is God's grace, Rahmat, it is His kindness that we have been able to connect with each other. So we thank God, we thank technology, we thank team FTC and our backend team from IGCP. We thank everyone for having made this possible, the fact that we are able to meet each other. But maximum thanks would be for someone known as Mr. Anand Basu. So I'd like to invite Mr. Basu to the stage. Sir.
I mean, I just cannot say anything over this because of the way you have summed up. Milna tujhe wala wala means I just cannot recollect it also, but I got the message that it's actually that we long for your weekend lecture on 9:30 every Sunday and diabetes essential, and this has become a part and parcel of our life. Even you have also shared that you look forward to be there with the audience which we have already gathered for last 3 years, and you can see from the questions coming across South India, North India, Western part and Eastern part, and the question answers which has been given and the prizes it's been a part of family of our every Sunday. So and actually when we had a off time during this World Cup and Diwali, we actually felt was a right decision or not, but that's how the life goes on. With this, I sincerely thank Sansay sir for really designing articulately the sessions for the coming January, February, and March. He has already discussed with you that he will be coming to a newer set of topics for the next week onwards, and already we are around at 9:51. I take such pleasure to be there with us. Thank you very much, sir. Have a good day and good night, and Jai Hind, sir.
Jai Hind.
Jai Hind, sir.